At the 2026 Healthcare Services Summit, in healthcare, the conversation around cleanliness often focuses on protocols, products, and compliance. But what about the people on the front lines making critical decisions every day? Well, this year's summit will take a closer look at the role of the hospitalist, those physicians who manage patient care inside the hospital, and the unique challenges they face in an increasingly complex environment. Joining us today to discuss all of this is Linda Liebert, Executive Director of the Healthcare Services Institute, a division of ISSA, along with Dr. Amrana Pasha Razak, a professor at the Department of Community Health and Social Medicine, City University of New York School of Medicine. Let's get into our topic today. And Linda, why don't you speak first about why you are pleased to have Dr. Amrana at this year's summit?
Dr. Amrana is going to be our keynote speaker. And what is so great about this keynote speaker is number one, she is a hospitalist, which is kind of a new title, but encompasses and begins to bring together, again, collaborative effort in patient safety and infectious disease. So we're real thrilled to have her as our keynote speaker.
I have worked with Dr. Amrana a few times in the past. I'm looking forward to this presentation as well. I'll be there for that. But Dr. Amrana, this term is new. This hospitalist is new. For those not familiar with that, how would you describe the role of this new designation, and why is it such a critical position within the healthcare system today?
So, hospital medicine, which is what hospitalists practice, is a new discipline, but a very old function within the healthcare system. So, physicians who take care of patients when they get admitted to the hospital are hospitalists. And in the past, internal medicine physicians, family practitioners, pediatricians who did outpatient medicine and also looked after the patients when they got admitted to the hospital fulfilled that function. However, what we have found is that when you have dedicated physicians whose full-time job is to take care of patients when they get admitted to the hospital, there is shortened hospital stays and improved patient outcomes. So I am an internal medicine physician, and for many years I practiced in the traditional way. I saw my patients in clinics, and when they got admitted to the hospital, I went to the hospital to see them. I transitioned to hospital medicine some years ago, and now I look after patients when they get admitted to the hospital only. I no longer do outpatient clinical work. I see when someone gets admitted to the hospital, I learn about them. I manage their care full time when they are in the hospital, as long as they are in the hospital. I coordinate care with other specialists. And I'm responsible for tests, medications, everything that encompasses their care as long as they are admitted to the hospital. And it's this improvement in outcomes and the shortening of the length of stay that has really driven us towards a more specialized discipline of hospital medicine.
Well, thank you. And Linda, I'm sure you're pretty excited about this. I suppose it's like a new angle coming to the summit. Is that true?
Well, it is a new angle. It's always nice to have a physician. And one of the great things about Dr. Amrana is the fact that she is focused on patient safety and patient care and the individual. And when we look at the healthcare environment, that is all a component of patient safety, patient care. And so it's important that those come together. And that's what's happening now with hospitalists.
Dr. Amrana, from your perspective, what are the biggest day-to-day challenges hospitalists face when it comes to maintaining those important, safe, clean, and infection-controlled environments?
So, as I've gotten to know more about the cleaning industry, I've really thought about this deeply. And I really want to break it down into sort of two areas. One is the care and safety of individual patients while they are in the hospital. So from the time they arrive at their room to ensure that there is a clean room, that whoever was being taken care of there before any infectious disease or any other contaminant that may move over into the second following admission has been removed safely, and that every day that they are there, they continue to be in that safe, clean, infection controlled environment, and that doctors and nurses moving between rooms who can transfer infections or other contaminants or bring them in from outside do not impact the patient's care, because that all gets cleaned up while the patient is admitted. So that is one person in one room, and that room being kept clean to a certain standard during their admission. But perhaps the other really important piece is that transitional piece that I spoke of. When one patient gets discharged and then you are getting ready to have a new patient in that room. So first of all, of course, the transition in terms of safety and cleanliness is very important. But the other piece that is very important from my view as a hospitalist is the time that that transition takes. So are we efficient and effective at, can we do this effectively and efficiently? Can we do it quickly? Because one of the biggest challenges that hospitals in the United States face currently is waiting time, especially waiting time in emergency rooms. So the vast majority of my patients get admitted to the hospital through the emergency room. And if rooms are not cleaned quickly after patients leave, then the next patient is waiting in the emergency room. And emergency room crowding is a huge problem in the United States. And one of the ways that we can improve that problem is by making rooms, what we call turning them around from one patient to another as effectively, so they're still safe. Of course, nothing can impact that safety, but that it's also done in an efficient way so that it can, so that lag time between the time one patient leaves and the room is ready to accept the next patient is as short as possible.
Yeah, I've seen lots of dramas and movies about hospitals dealing with this, so it's reality according to what you just shared in this country. But let's talk about where the rubber meets the road. You talked about the practice of all this, but do you have any specific experiences where when all of this was implemented, you saw a good outcome for patients?
Right. So I'll go back to pre-hospitalist times when I was training many years ago in New York City. Um, we used to have a very long lag time between the time patients were discharged and the times that the next patient was accepted into a bed. And a lot of that was very human dependent. After the patient left, which could be in those days any time of the day, the patient could be discharged at 7 p.m. The patient could be discharged even later at night or any time during the day. And then the unit in receptionist or the person at the front desk would call up custodial services and say, we have a bed waiting to be cleaned. Now we're waiting. I, as the resident physician, would say, hey, my patient's in the ER. I'm waiting for them to come up. And they would tell me, well, the bed's not clean. And then a few hours later, swing by again, bed's still not clean. I'm still waiting for the staff to come up. And sometimes, by the time the patient left at 8 p.m., the night shift is come on of the custodial staff. It's only a skeleton staff. So for them to staff those rooms and get them cleaned up, it takes longer. And so that patient that's waiting in the emergency room is still in the emergency room. And overnight, you would have multiple beds that were not clean and whose patients were waiting. And I saw this many times as a resident. One of the things that improved was entirely dependent also on human effort. Our department chair, the chair of the Department of Internal Medicine in my hospital, started making what he called go home rounds. That was when he was on his way home. His office was on the 19th floor. He would walk down floor by floor from 12th floor down to all the floors where internal medicine patients were housed. And he would check on every floor to say, how many patients are supposed to be going home today? Have they gone home? And if they haven't, when are they leaving? And when will this room be cleaned? So he tried to fit as many discharges as possible into that time before the night shift came on, before that skeleton night shift came on, so that beds could be cleaned and patients could be brought up from the emergency room before it became 9 p.m. and the shift changed. Simply by saying, can you make sure that patients are being moved out? When I came back to hospital medicine many years later, I found that this problem had been really improved in many ways, not to say that we can still not do better, but for one thing now, as hospitalists, we aim to discharge our patients. Every hospital has a slightly different number, but 10 a.m., 11 a.m., noon. Noon, I would say, is probably the latest. We want to get our patients who are being discharged out of the hospital. So as in the room is now empty by that time. And the hospital evaluates our performance based on this metric. How many patients do you get discharged by that time? And that I have learned as I've worked with ISSA and with others in the cleaning industry. Part of that push is so that the custodial staff are at their most efficient in terms of the number of their staffing, how many people they have on hand to go and quickly clean all of those rooms. For example, if 5 or 6 rooms were to become empty on a single floor, they could go through them very efficiently one after the other and get them all cleaned and ready to accept the next round of patients. Whereas if people were being discharged sort of piecemeal, one person here at 10 a.m., one person on another floor at 2 p.m., and they're having to move between floors, all of that takes much longer. So trying to get as many beds on a single floor empty at a similar time so that they can work their way through those rooms and get them ready for the next has been a major step forward. And of course, the use of digital technology has really helped all of this, because now you do not need someone to call up and say, come and clean the bed. There are hospital dashboards which show when the room is empty. And facilities services also share the same dashboard with us, with the healthcare personnel, so they can see when nursing marks patient has left the hospital. That will pop up on the facilities dashboard as room is empty.
Linda, that sounds like the cleaning industry needs to step up.
Well, definitely. So, a couple of things here. The Accountable Care Act is part of the reason for room turnover times being shortened. But at the same time, one of the things that is of concern is when hospitals are designed and constructed, they're not designed and constructed for cleaning. And so oftentimes what happens is we have a room that needs to be turned over quickly, and the products and the materials that were used in there are more difficult to clean. So, we really need to start from a foundation of, we've got to build hospitals that are easy to clean and disinfect effectively and turn over so that the patients are being taken care of better. So, we're working at this from all angles here, but most important is we want to make sure that our EVS professionals are trained to be able to be efficient in turning over these rooms and making sure that they're safe for the patient. So I love Dr. Amarana's explanation of, what's happening to the patient in the emergency room. They're just sitting there waiting to be taken care of and taken to a room where they're more comfortable.
Agreed. Dr. Armana has seen a lot of things in her career, and those observations hopefully will lead to more improvements as we see the cleaning industry step up to help the healthcare industry, and they all join forces to make things safer for patients. Dr. Armana, we're about out of time, but during your presentation at the summit, what you just shared with us, what can people really expect to take home to make real changes from what you're going to share with them?
So, I really am a huge advocate of what we in medicine called interprofessional practice. Interprofessional practice is recognizing that patient care is not a one-man show. It is not a top-down activity. It is a team sport. So interprofessional practice involves we have what are called interprofessional rounds in the morning. So nurses are there, physicians are there, as would be in most rounds, but also social workers are there, and physical therapists are there, and other people who take care of patients. We all get together as a team and we discuss every patient and say, what does this patient need today? What is our forward planning? This patient's going to be discharged in 2 days. What I would love to see over time is not us thinking about this in two streams, in two silos, where there's the cleaning industry and the healthcare industry, but recognizing that our facilities staff are an integral part of that interprofessional practice, and that there is someone from the facilities management, for example, there's no evidence for this yet, but I think that their presence on those rounds might be something that would facilitate both their integration into the teams and a recognition of the importance of their roles by the rest of us, but also allow them to function more efficiently. If they had an idea that, for example, 2 days from now, there's going to be a huge number of patients that doctors are planning to discharge, they may say, okay, I need to call extra people in for Wednesday because on Monday's rounds, I heard that there are so many discharges planned for Wednesday. And, they are, but should be recognized to be an integral part of that interprofessional team, because we can't function without their input.
Absolutely. Well, this will be a great summit. I'm looking forward to being there, Dr. Armana, for your presentation. And Linda, I know you're happy and proud of what's coming together as a successful event. And how to register, we'll put that link below. But Linda, any final thoughts?
No, well, sign up quickly. We are selling out. There's only 120 seats. And we do that because we like the intimate networking opportunities and then the ability to develop projects for the year and implement them. And so sign up as soon as possible.